Welcome to this infection section. My name is Erin Alea. We have a really nice lineup of speakers today to talk about infection of bones, soft tissues, spine infection, and intervention with musculoskeletal infection. So I'm going to be kicking off the series today talking about osteomyelitis. Okay. Trying to move my mouse. Okay. How do I advance to the, I'm sorry, play? Sorry. Advance to the next slide. I press play.
You just have to click on it.
Got it. Okay. Okay. Sorry about that. So here's my disclosure. So today in my lecture, I'm going to be reviewing the characteristic imaging features and accepted nomenclature for osteomyelitis. And today I'm going to be focusing on findings specific to the adult patient, and I'm going to be talking about MRI as a modality. I'm going to be reviewing pearls and common pitfalls for MRI and suspected osteomyelitis, and I'm going to be showing you a few challenging cases that I've seen in my clinical practice and how I approach them. So a lot of the recommendations and nomenclature that you're going to be seeing throughout my lecture are really based upon the 2020 Society of Skeletal Radiology white paper, which was on MRI nomenclature for musculoskeletal infection, and this paper was led by Bill Morrison, who is one of our other speakers today. So osteomyelitis is an infection of bone involving the medullary canal. Now, this is an MRI-focused lecture, but I think it's important just to emphasize that radiographs are always going to be the primary modality for the diagnosis of osteomyelitis. Radiographs are cost-effective and they're readily available, and often they'll just really nicely show the findings. And here's a nice example of radiographic osteomyelitis. You can see profound demineralization in multifocal areas of cortical destruction. Now, MRI is going to be indicated for the diagnosis of osteomyelitis when radiographs are negative or indeterminate. So these radiographs were read overnight by an emergency room radiologist who questioned the cortical irregularity along the tuft of the fourth distal phalanx. An MRI was recommended, and on MRI we easily see osteomyelitis with confluent marrow signal replacement of the fourth distal phalanx, but also the fourth middle phalanx. And this is important to emphasize that MRI is also going to show really the extent of osteomyelitis. That fourth middle phalanx osteomyelitis was not apparent on the radiographs. MRI is the best modality that we have to offer our patients for the diagnosis of osteomyelitis, having a high sensitivity of 90% and a specificity ranging from 79 to about 82.5%. What we're looking for to make a confident diagnosis are these concordant signal changes on MRI. So confluent low signal on T1 weighted images and matching high signal on the fat-suppressed fluid-sensitive images. And that's what we're seeing here in the fifth metatarsal. Now, occasionally we administer intravenous contrast. An infected, viable bone is always going to show marked enhancement. We don't need intravenous contrast to make a diagnosis of infection in viable bone, but it's going to be very useful for infection of non-viable bone, as we'll see later in the lecture. Now, it's really important when you're reading any MRI for suspected osteomyelitis that you find the ulcer or the sinus tract. In fact, this is the first thing that I do when I open up the case. And why is that? It's because the vast majority of osteomyelitis cases that we read are in patients with a diabetic foot infection. And in the foot, osteomyelitis almost always occurs due to contiguous spread. So the infection seeds the ulcer, it spreads to the soft tissues, and it's going to infect the adjacent bone. So the osteomyelitis will occur right next to the ulcer or sinus tract. Now, in most cases, such as this, it's going to be readily apparent. Here we see an obvious sinus tract leading to the first metatarsal where we see osteomyelitis. But occasionally an ulcer can be quite subtle, and for this reason, if it's not obvious, I'll open up the clinical exam, I'll look for an image ideally, or a physical exam from vascular surgery, infectious disease, or podiatry. Now, the first thing that I look at when I'm reviewing an MRI after I've found the ulcer is the T1 signal pattern. This is really important. And what you're looking for is T1 marrow signal replacement in a geographic medullary distribution with a nice confluent pattern, as we're seeing here, along the greater trochanter. So prior study by Collins et al. Has found that this pattern has a very high association with osteomyelitis. Now, there are other T1 findings that we commonly see. So, for example, we may see a reticular pattern of signal abnormality. So it's this sort of lace-like pattern of low T1 signal, but with interposed areas of fatty marrow. Or we may see a subcortical distribution, where we see low T1 signal, but it's very thin and it's paralleling the cortex. These patterns overall have a lower association with osteomyelitis. What's also going to be important is the degree of signal abnormality on the fat-suppressed fluid-sensitive images. So here we see osteomyelitis of the first metatarsal with a surrounding abscess that is fluid signal. And as it turns out, marrow signal changes that approach that of joint fluid, such as what we're seeing here, are going to have a higher likelihood of osteomyelitis. But what we often encounter in our clinical practice is discordant marrow. So what is discordant marrow? It's when you see high signal on the fat-suppressed fluid-sensitive images in the marrow, but we don't have that matching confluent low T1 signal that we expect to see for obvious osteomyelitis. Now, the SSR white paper group has recommended that in cases of discordant marrow, you really look at the regional soft tissues. And if we look at the regional soft tissues, we're seeing a broad area of ulceration along the dorsal and medial first digit with adjacent cellulitis. The recommendation of this panel is that when you have marrow signal changes adjacent to an ulcer, sinus tract, or soft tissue infection, abscess, this should be reported as high likelihood of osteomyelitis, really regardless of the T1 pattern of marrow signal abnormality. And we should really abandon use of this nebulous term reactive osteitis, which has no clinical meaning. So to further emphasize discordant marrow and how we should describe it is this study coming out of Penn State looking at outcomes in diabetic foot ulcer patients with adjacent discordant marrow signal changes. And this group found that 61% of cases either had an initial histologic diagnosis of osteomyelitis or progressed to osteomyelitis. This study also had another important finding, looking at ulcer depth and risk of osteomyelitis. So ulcers that were deep, greater than 50% thickness of the subcutaneous fat, or if there is a sinus tract leading to bone, 71% of those cases had histologic osteomyelitis, with only 28% of the superficial ulcers showing osteomyelitis. So ulcer depth matters. To understand how a patient with discordant marrow signal has osteomyelitis, let's look at the expected evolution of marrow signal changes. So as we discussed earlier in the lecture, in the foot, osteomyelitis almost always occurs due to contiguous spread. So it starts with the ulcer, the infection extends to the soft tissues, the cortex of bone, and at a later stage, the medullary canal. The first finding is always going to be high signal on the fluid-sensitive images. It takes time for fatty metabolization to occur in order to produce the low T1 signal that we see later in the infection. You also need an intact, robust vascular supply. So if we have a patient with lack of vascularity or poor vascularity in the area of infection, or if we capture this patient with MRI earlier in the disease prior to that fatty metabolization, we may have a patient with osteomyelitis and we see discordant marrow signal. We talked about intravenous contrast earlier in the lecture. Now, intravenous contrast is going to be very useful if you have devitalized bone. And here we see an area of devitalized bone along the first distal phalanx tuft, where we're seeing a geographic area of non-enhancement of bone, as well as the overlying soft tissues. Now, this devitalized bone and soft tissue is not taking up intravenous contrast, so it's never going to be treated by circulating IV antibiotics. And here's another example of devitalized bone and soft tissue. And it's for this reason that we really need to find the devitalized bone and soft tissue and report it. It's often going to be targeted for debridement or resection. It's also important to look for any exposed bone. So remember, there's a high positive predictive value of a positive probe to bone test. And here's an obvious example of exposed bone of the fifth metatarsal head, as well as the base of the fifth proximal phalanx, where we're seeing osteomyelitis with really nice confluent T1 marrow signal replacement. But exposed bone is not necessarily going to have an intact vascular supply. So here's an example of bony exposure of the middle and distal phalanges. Now, more proximally here along the proximal phalanx, we're seeing obvious evidence of osteomyelitis with confluent T1 marrow signal replacement and enhancement. I was initially reading this case with a trainee who said that the middle and distal phalanges were magically spared from infection. But we know clinically that that doesn't make sense. It's much more likely that this exposed bone is devitalized, so it doesn't have the ability to enhance or show the low T1 signal and is infected. Here's another case that was read as no evidence of osteomyelitis, and we see a deep heel ulcer extending to the cortex of the calcaneal tuberosity. And what do we see there in the marrow? We see a large area of serpiginous marrow signal abnormality. Now, osteoclasts aren't going to be able to get into the area of infarct to resorb bone. You're not going to have that fatty metabolization producing the low T1 signal. So this also should be reported as likely infected devitalized bone. Here's a case of unreliable marrow signal. So I read this case with a trainee. The technologist called and said that the MRI scanner was not working. So normally we would expect to see nice fatty marrow on T1 weighted images, but instead we're seeing the marrow is diffusely low in signal. And incidentally, we also see high signal on the fluid-sensitive fat suppressed images, really the opposite of what we should see. So as it turns out, this patient had both renal and heart failure and had gelatinous transformation of the marrow, or serous atrophy. And this is a marrow transformation that we see in patients with chronic disease or malnutrition. So in this patient with unreliable marrow signal, we had the benefit of an MRI from 3 months prior. And on the MRI from 3 months prior, what we're seeing is a broad area of soft tissue ulceration, adjacent to which we're seeing enhancement of the first metatarsal head. And on the current exam, we're seeing a new large erosion. So this combination of findings on prior MRI with a new erosion led us to describe this case as high likelihood of osteomyelitis. Let's talk about osteomyelitis and Charcot arthropathy. So often we're asked to evaluate for any osteomyelitis in a patient with Charcot arthropathy. And unfortunately, patients with Charcot arthropathy and no infection have similar findings. For example, they show cortical destruction, but it's always going to be in a periarticular distribution. They show soft tissue fluid collections, but this is actually just a bland fluid collection, most likely. And I think that it's most likely bland because if you look at the regional subcutaneous fat, it has a rather clean appearance. We're also not seeing any associated ulceration or sinus tract. So this is probably a large adventitial bursa in a patient with Charcot arthropathy and rocker bottom deformity. Charcot patients also show marrow signal changes on the fluid-sensitive images, but it's almost always going to be in a periarticular distribution. And when we go back to the T1 weighted images, I'm seeing that reticular pattern of T1 marrow signal replacement. I don't see confluent low T1 signal. So this patient came back 4 months later, and we're seeing a broad area of ulceration overlying the medial cuneiform. And now we go back to the T1 images, and we see a new confluent T1 marrow replacement along the medial cuneiform, which is deep to the ulcer. So this combination of findings is enough to say high likelihood of osteomyelitis. Here's another case of Charcot-arthropathy, and we're seeing a broad sinus tract along the plantar aspect of the midfoot, adjacent to which we're seeing an area of confluent T1 marrow replacement. So similar to other diabetic patients without Charcot-arthropathy, if you see marrow signal abnormality adjacent to cellulitis, sinus tract, or ulcer, particularly when you see that confluent low T1 signal, this should be reported as high likelihood of osteomyelitis. Finally, let's move on to chronic osteomyelitis. So here we see fluid-sensitive and contrast-enhanced images at the level of the proximal tibial metaphysis, where we're seeing a large intraosseous fluid collection. It has that very thick rind of peripheral enhancement. So this is an intraosseous abscess, or a pus-filled cavity with an enhancing rim of granulation tissue. Here's another nice example within the calcaneal tuberosity. Now we really count on that enhancing peripheral rim of granulation tissue to help make the diagnosis. But unfortunately, we don't always have contrast on board. So when you do not have intravenous contrast, you can actually use two other tools to help make a diagnosis of either intraosseous or soft tissue abscess. And one of the most useful findings that you can look for is presence of what's known as the penumbra sign. And this is just a really beautiful example of the penumbra sign in that calcaneal tuberosity case, where we're seeing this rim of relative high T1 signal along the periphery of the abscess cavity. This is really going to increase your diagnostic confidence for bone or soft tissue abscess. You can also do diffusion-weighted images, so a bone or soft tissue abscess will show restricted diffusion. That's also going to be very useful. Our next case here, we're seeing this focus of low signal along the proximal humerus. So this is a sequestrum. This focus of low signal within the medullary canal seen in chronic osteomyelitis is actually a focus of necrotic bone. And it's very important to be able to identify and to report a sequestrum, because this dead bone is not going to be exposed to and treated by any circulating IV antibiotics. Surrounding the sequestrum is going to be this capsule of viable new bone. It's going to show a rind of enhancement around the sequestrum. It's known as the involucrum. And then finally, the body sort of tries to deal with this chronic infection by forming what's known as a cloaca, or this cortical defect that acts to try to expel any pus in the medullary canal and occasionally the sequestrum. And it's important to identify not only the cloaca, but also the sequestrum, because sequestrectomy and complete opening of the sinus tract is going to be essential for completed healing. So that was my talk on osteomyelitis. So there are several important take-home points. Remember, in the foot, which is the vast majority of what we read in clinical practice, osteomyelitis almost always occurs due to contiguous spread. The osteomyelitis is always next to the ulcer, and this is why the ulcer is such an important secondary sign. It really improves our diagnostic confidence. T1 marrow signal in a geographic medullary distribution with a confluent pattern has a very high association with osteomyelitis. But often we see discordant marrow signal, and hyperintense marrow signal on fluid-sensitive images adjacent to an ulcer, sinus tract, or abscess should be reported as high likelihood of osteomyelitis, really regardless of the T1 signal pattern. Finally, IV antibiotics are unlikely to reach non-enhancing, non-viable bone. So non-viable bone, which will show geographic non-enhancement, really needs to be recognized and reported. Thank you. So next we have Dr. Bill Morrison, who's going to talk about soft tissue infection.
Thank you. And while that's loading, I tore my gastrocnemius last night jumping over a puddle, so apologize for my, I'm not strutting, I'm actually limping. But you cannot talk about soft tissue and bone infection really separately. And Dr. Alia's excellent talk was bone with a smattering of soft tissues. Mine is going to be complementary and talk about soft tissues with a smattering of bone. So I am going to get started here. So first, conflict of interest, nothing really that applies to this. First of all, I want to talk about the modes of spread. So there's 3 basic modes of spread for infection in the body in general, and that's hematogenous, direct implantation, and contiguous spread. And all of these have soft tissue components or flavors that we're going to talk about. Hematogenous infection, we've been talking about in the last talk, can give you septic arthritis, osteomyelitis, or even discitis in the spine. And it has secondary soft tissue involvement, which we'll touch on. Direct implantation, stepping on something, open fractures, punching someone in the mouth, things like that, which never happens in Boston, I'm sure, gives you primary soft tissue effects and also secondary effects from the bone infection. Then there's contiguous inoculation, which we've heard about with diabetic patients and also that you get in the pelvis with paralyzed patients, which gives you primary soft tissue effects and secondary bone involvement. So all of these have different flavors. We'll talk about soft tissue effects of hematogenous infection first. So here's a 16-year-old male that had hematogenous osteomyelitis with Staph aureus, and you see periosteal reaction there at the lateral aspect of the, and I don't know how to get this mouse over to the other computer screen. Anybody? Oh. There it is. Excellent. Great. So there's this kind of permeative pattern of bone destruction there, periosteal reaction. And you see on MRI the soft tissue, kind of secondary involvement of the soft tissue from this hematogenous infection. Here's the same case while we're doing a biopsy, because at this stage, the differential diagnosis included things like lymphoma and Ewing's and things like that. So we biopsied it even though we thought it was going to be infection. But you can see how it's kind of necessitating out toward the skin surface. And that's kind of the natural history. If you don't do anything about these bone infections, the body will try to heal itself. And that involves what Dr. Elias said, is forming a sinus tract and expressing the infection out through the skin. And here's what happens if you really don't do anything about it. You develop chronic osteomyelitis, this in an unfortunate pediatric patient who developed chronic infection of the tibia. And here they have a sequestrum, which is not getting contrast on post-contrast imaging. So again, like Dr. Elias said, this is not going to be effectively treated with IV antibiotics. And you see all the soft tissue inflammation around it, forming a shell of living bone around the sequestrum. That's called the involucrum. And eventually, in chronic osteomyelitis, you may form a sequestrum. And here is the sinus tract and cloaca. And that's, again, your body's natural way of dealing with these infections is to express the infection through the skin surface and through that sinus tract. And if you read these old accounts of people with infections from battles in the Revolutionary War or things like that, they'll have things like popping out of their sinus tract periodically, pieces of bone and things like that. So these sequestra can actually come out through the cloaca, actually. Now let's talk about septic arthritis. So septic arthritis can look like any kind of inflammatory arthropathy. But if you notice here at the left hip that you see, bone destruction, you see subchondral changes here, collapse of the surface of the bone, you see effusion, complex joint fluid, and things like that. And what you'll notice, especially on post-contrast imaging, but also on FATSAT T2, is that there's a lot of periarticular enhancement here. And so that really helps characterize an inflammatory, really infectious joint effusion compared to a chronic, non-infectious inflammatory condition. So I call that an angry effusion. And when you see that, it's not necessarily going to be infection, but have a high index of suspicion that this might represent an infection instead of just chronic inflammatory arthropathy. So let's contrast that appearance with this patient that has rheumatoid arthritis of the elbow. And the reason why you don't see this periarticular edema that you saw in the septic arthritis case is because the effusion happens slowly and expands the capsule, and that's why you get things like ligamentous laxity in chronic inflammatory arthropathies like rheumatoid arthritis. The capsule expands, the periarticular ligaments expand, lead to joint instability and things like that. So notice that you have dirty fluid here. You have actually not much fluid. You have a lot of synovial proliferation. You have mass like synovitis. But notice the absence of that periarticular or angry effusion that we saw with infection. This is especially true in small joints. So small joints, you think of fingers and SC joints and sacroiliac joints. Small capacity joints, the infection in that joint will pop out of the capsule early on and give you, especially commonly, that angry effusion kind of look. So here's septic arthritis of the finger with a lot of periarticular edema. And I always think of Chris Farley when I see these types of things because, you know, Chris Farley was an amazing comedian, but he was a large man, and he always wore a very small outfit to accentuate the comedic effect of being large. And so that's what I think of when I think of angry effusion or septic arthritis bursting out of the capsule. So here in the sternoclavicular joint, same thing. We have an effusion, but look at all that periarticular edema and enhancement. You think about infection. Large effusion in a small joint. Septic arthritis of the sacroiliac joint, another small capacity joint. We have erosions here. We're setting up for biopsy, obviously. We have loss of that subchondral white line, which is seen on the other side. So classic septic arthritis and erosions. And again, the Chris Farley effect. We have an angry effusion. We have periarticular soft tissue edema. So this is the great imitator. Someone that has septic sacroiliitis, they often present with sciatica because the sciatic nerve is right under there in the sciatic notch. And so they get inflammation of the sciatic nerve. They go to their family practice doc, and what do they think? They think you have a disc herniation, so they'll get a lumbar spine MRI. And your job, really, as a radiologist, is to look at the very edge of the image and look for the edema at that sacroiliac joint representing septic arthritis, because you will be the one that will get them seen early for infection. So, large effusion, small joints, angry effusion, think about septic arthritis. Now, this can also lead to soft tissue effects leading from the joint into the surrounding soft tissues. An infection tends to spread from the joints along fascial planes, which can lead to abscesses forming in the gluteus musculature, as in this case, sciatic notch, as we saw earlier, and in this case as well. And it can even spread along the spine. And here's a patient with discitis, and of course, the same effect occurs there. Small capacity joint, in this case a disc, infection bursting out of it. It goes either into the psoas muscles, paraspinal soft tissues, or the epidural space. Now let's talk about soft tissue effects in contiguous infection and direct implantation. So pay attention to spread. It's very important. You've identified a soft tissue infection. Congratulations. Now your second job is to look where it goes. Where is it going? Where do you have to tell the surgeon to open up exposure-wise? So we have this soft tissue edema here on radiographs. We see it on MRI as replacement of T1 signal in the subcutaneous tissues representing cellulitis. We have this abscess surrounding the Achilles tendon. Now I need to tell the surgeon how far it's going, because they need to know how far, exposure-wise, they need to open the patient up to treat this effectively. Here are two different examples. On the left, we have an ulcer at the medial aspect of the forefoot at the plantar surface, and actually the infection is spreading through the intermetatarsal space all the way up into the second extensor tendon and then back to the midfoot. So that's something you really need to identify. Whenever you see something, an ulcer, abscess, sinus tract or something, just look where it goes. If there's any tenosynovitis coming from that area, it's suspicious, it's suspect. Here's a shallow ulcer over the calcaneus. We have adjacent cellulitis. Yes, we have osteomyelitis there. But we told the surgeon that infection spreads all the way up to the Achilles musculotendinous junction. And so they exposed the patient all the way up to here, and they had abscess going all the way up to that area. Here's a patient with septic tenosynovitis. It actually arose from a septic arthritis Here's the clinical image. Here's the radiographs showing soft tissue prominence there, ultrasound showing tenosynovitis. And here we see the MRI showing the septic tenosynovitis extending all the way up to the hind foot. And this has access to the lower leg, and very important to identify the end of the infection. Here's a patient with abscess extending along the deep compartment of the foot. So we have an amputation here, we have some soft tissue prominence, and actually this had become reinfected. And if you look on the MRI here, T1 with replacement of fat signal in the subcutaneous tissues, and we have fluid extending from that area of infection at the forefoot all the way along the deep compartment, along those flexor tendons to the hind foot. And that, again, has access to the lower leg. Very important to identify the extent of infection in these cases. Another example, a patient that had an amputation. They have opening up of a wound here at the dorsal aspect of the hind foot. Looks like a tract going all the way to the navicular bone. And here we do the MRI, and it's actually not just that, but actually implantation of the ankle joint with septic arthritis. And you probably know the ankle joint and subtalar joint often communicate, and these often communicate with the flexor hallucis longus tendon as well. This patient actually had not only septic arthritis of these joints and osteomyelitis, but also infection extending to the lower leg through the FHL sheath. So very, very important again. Contiguous spread. This is a non-diabetic patient who unfortunately was casted with a wound, and they developed this group B strep, the so-called flesh-eating bacteria that spread into the marrow compartment in this case. Very sad case. But most of the cases of contiguous spread that we're seeing are in patients with diabetic infections. And these form in areas of callus. They form ulcers, usually over sites of pressure, the first and fifth metatarsal heads, calcaneus, especially in bedridden patients, or the malleoli, or in areas of deformity. If you have arch collapse, rocker bottom deformity, you can form ulcers underneath the cuboid. Patients with diabetes and neuropathy, they often get claw-toe deformities, and you'll get dorsal ulcerations over the toes or at the tips of the toes. So those are the areas to look. These calluses break down, they form ulcers, and lead to contiguous spread of infection. Cellulitis, it's very helpful to look at the post-contrast images, except if they are devitalized. But one thing that's very helpful, especially if you're not giving contrast, is to look at the T1s. The T1 spin echo is extremely useful in musculoskeletal imaging, and especially for infection. Cellulitis will show up as replacement of the subcutaneous fat signal. You'll find in diabetic patients, a lot of diabetic patients have diffuse soft tissue edema. So our fluid-sensitive sequences are not always the best in differentiating bland edema or non-infectious edema from infection. So look at your T1-weighted images. If you give contrast, look for enhancement. And you'll find actually that there is often sharply defined enhancement pattern when you see cellulitis in these patients. And second job, again, look at where the infection's spreading. Find the ulcer, and look what it's doing. Here we have an abscess forming in the soft tissues. Here we have a tract extending to the phalanx of the great toe and forming osteomyelitis there. Here we have a shallow ulcer at the dorsal aspect of the midfoot, extending into the Lisfranc joint and hindfoot, representing septic arthritis and osteomyelitis. And again, like Dr. Elias said, in diabetic patients, the vast majority of osteomyelitis of the foot is created by these contiguous spread from soft tissues. So find your tracts, find your ulcers, see where they go. In this case, extending to the distal phalanx. Patient was treated medically, which is often the case, and we re-imaged, and now they have spread to the proximal phalanx. So very often what happens is that we get the MRI for diagnosis. They're treated either medically or surgically, depending on what the patient can tolerate or what the clinicians think is best, and then we re-image and see what the effect of the treatment was. If they progress or they don't improve, then they typically go to surgery. Here's a patient with an ulcer over the first metatarsal head. And notice here on MRI, we don't really have a joint effusion. No angry effusion, no nothing. And the reason is because this is draining out. So it's very important. Another principle is that when you have ulceration over a joint, you'll very often not see an effusion there because it's draining out as soon as it collects any fluid. One thing that's important to differentiate is gout. Gout is a very close mimicker to infection, can look a lot like infection. I thought this was a diabetic patient with osteomyelitis. They have muscle atrophy throughout the foot. They have a fluid collection here, destruction of the first metatarsophalangeal joint. And actually, this was a patient that had gout. Dr. Elia talked about the challenges in looking at neuropathic osteoarthropathy with superimposed infection. And really the key here is the soft tissues. So we have neuropathic disease here at the midfoot, but we have replacement of T1 signal in the subcutaneous tissues, ulceration. So that represents classic breakdown of callus and ulceration. We actually have a tract, sinus tract, extending from that ulcer all the way to the first cuneiform bone, and edema, slight replacement of T1 signal there as well, and that's going to be early osteomyelitis in this patient with Charcot arthropathy. All right. There we go. Now, in abscess and necrosis, here's a Bologna amputation with a large abscess. We gave contrast, and we see this area of abscess formation surrounding inflammation, very slight edema enhancement. Again, we have kind of discordant findings. Again, as Dr. Elia suggested, we tend to throw out the term osteitis. We want to expunge that term from our literature and our clinical use because this, again, is probably going to be early osteomyelitis if you see edema there next to an area of soft tissue infection. And actually, in this case, the abscess leading right to that open cortex. As she mentioned, necrotic tissue is not going to get IV antibiotics to it, so you have to identify this. It's very helpful for the surgeons in planning their procedures. So contrast is very useful to give if you're able to give it. We always check renal status before we give it. But here's a post-contrast image showing rim-enhancing abscess around the iliac bone, in this case, and non-enhancement of the iliac bone itself. So that is important to tell the surgeon that that area is devitalized. And oftentimes what you'll see is that these look like infarcts. You know, especially in the feet, we'll see these non-enhancing, well-defined areas that look like a organ infarction. And that's really what they are. And you'll often see areas of hyperemia and increased enhancement around that area representing the tissue at risk. So again, these areas either need to be debrided or revascularized in order to treat them effectively. And here's another example. Again, you can kind of draw mental lines around these things and see the area of hyperemia and the area of non-enhancement. So we actually do pre and post imaging and we compare them. And you can do subtraction images if you like. We look for areas of non-enhancement, representing areas of devitalization here around an ulceration at the heel. Now let's finish up with some uncommon stuff. Atypical soft tissue infections occur. This patient had traveled to the southwest and developed coccidioidomycosis. Looks a lot like tumor, lymphoma, so there's tumor-like presentation of a lot of soft tissue infections, especially atypicals. This patient had underlying endocarditis and developed these abscesses in the soft tissues all around their body. This patient had AML and developed pyomyositis. So always think about infection, atypical infections, especially if they're immunocompromised or things like travel history. Muscle edema, soft tissue findings are very nonspecific. So history is essential. You can have all these soft tissue things can be injury. You can have edema from neurologic causes or ischemic etiologies, other inflammatory conditions as well. So always keep those things in mind. MRI gives you the big picture. Is this Michelangelo's David, or is that an osteochondral lesion of the talus? Is this mother and baby, or is this a ganglion cyst? Is this the screen by Edvard Munch, or is this normal anatomy? So MRI gives you the big picture, especially regarding infection, and thank you so much for your time. And now we'll bring up our next speaker, Dr. Simpfendorfer. If I can figure out how to get this off. There we go.
How do I go? Is it? All right, so then I go like that. And should be loading me now.
Yeah, you just
Right, then I
press
have-
play.
Okay, then how do I go through? Okay,
You just slide
perfect.
over like this.
Yeah,
Just slide over.
kind of slide over. Yeah, okay, got it now. It's kind of backwards. All right, so now we're going to cover spine infections. So we're going to review the clinical presentation and imaging findings of spondylodiscitis. We'll also look at some of the mimics of spondylodiscitis and kind of discuss how to differentiate them, and then review imaging findings of septic facets and how this differs from spondylodiscitis. So spine infections, it's a big deal because it actually keeps increasing all the time. So over the past couple decades, about a 40 to 160% increase since roughly around 2000 to now. And this is because of the expanding aging population everywhere. We also have indwelling lines all the time, much more invasive procedures, along with just the increased availability of MRI. As a result, we diagnose them more frequently. So we did talk, everybody's actually so far talked about spread. In this case, we're just talking hematogenous predominantly. Now, surgery is obviously a way that you'll get infections. You know, they try to keep the infection rate to less than 2% in all sort of spine and orthopedic surgeries. And then soft tissue infection in the spine is uncommon. I mean, this is an example, and one of the only ones I have of coming from somewhere else with Crohn's fistula. But in this case, hematogenous spread is the way that it gets there. So pathology, this is, I mean, it's in the United States, it's basically Staph aureus, Staph aureus, Staph aureus in the vast majority of cases with spattering of other bugs. The one interesting thing from my ID colleagues that they end up telling me, so 90% of all these infections will be covered by vancomycin and about 95% of them with empiric therapy, leaving the last 5% what we're typically trying to target with biopsy. So in this case, you know, patients present with back pain, neurologic deficit based on where it is. The higher you go up, the higher the incidence of neurologic deficits. Fevers are uncommon, and then obviously risk factors, whether someone has IV drug abuse, indwelling lines, diabetic. The infection starts basically in the anterior, or well, basically at the edges of the vertebral body, and then cross across the disc space into the other side. That's why we usually see early on. And then this is sort of one of my best examples of a early infection, just showing the edema at that disc space and in the immediately adjacent end plates. As it spreads, it then starts to spill out. Just as Dr. Morrison said, the small space, then it basically spills out quicker into the adjacent tissues. And we use this for all infections to look for edema, whether it's a septic joint or the spine. And this, with a florid example of a really bad infection, we can see the both anterior and posterior spread. And on the axial images, basically we'll see it spill into the paraspinal soft tissues, similar as in this case where we have bilateral psoas abscesses, which also ends up being a nice point to target if you are doing an intervention, as it's much nicer to aspirate fluid for your cultures than it is to get a biopsy sample. So on MRI, which is predominantly what we're talking about all the time in MSK for infections especially, you know, we're going to be looking again for that T1 hypointensity, high signal on T2, basically involving the end plates of vertebral bodies. The disc space will end up with some fluid signal. And then if you are giving contrast, which is very helpful in these cases, you'll also see this enhancement, often a bit nodular enhancement along the disc space. It also helps outline any paraspinal edema and enhancement as well. And this adds more specificity to the exam. Again, going to the soft tissues that we were talking about. In this case, we're talking about spread from the disc space outward to the sides. And this is what helps us differentiate this from more benign processes, just like degenerative disc disease or something else, but basically infection, you're looking for that edema. And the psoas sign, which is kind of portrayed here with the edema off on the side. And then this will also, if you give contrast, enhance as well. Now, if you end up with the psoas abscess, this is almost pathognomonic. Now, nothing is really always 100%, but basically every time you end up with the psoas collection, this is going to be infected. In the cervical spine, look for the prevertebral edema. This is a nice way of seeing, first off, that something is going on in that area, and then try to identify the level. And then it's even easier if you end up with an epidural abscess as well, knowing that that is an infected disc space down lower. If you're unable to get an MR, CT is typically the modality of choice, at least at my institution. Now, if you're able to get away with a PET CT, great. That is actually very, very effective. Just the majority of the time, it's not going to be approved. Give contrast on the CTs. This will help you evaluate the soft tissues and look for small psoas collections. And then you can also see the erosions of the end plates much better on CT than MR. And in some questionable cases, before we're going for a biopsy, we'll sometimes do this to try to delineate whether or not we think one is necessary. So here's a case of someone who had a posterior lumbar interbody fusion a couple months post-op, was having pain. They did an MR, and you can see the marrow changes in the end plates that are shown here, along with a very funny-looking appearance at the level where they did the discectomy and interbody fusion. But when we go to CT, we can clearly see that these erosive changes here, which are much more prominent, is clearly not something that is following surgery and a result of infection. So in review on MR, we're looking at the T1 weighted signal abnormality with corresponding T2 fluid sensitive sort of edema signal, edema in the disc space. Following contrast, you'll see some enhancement. And then if you get a CT scan, all of these on the same patient, you'll see the erosive changes much better. Now, the problem that we run into with spine infections is the diagnostic delay that there is. So this is way back in 1986 when they described this in a paper. And currently now, we're doing better, but still not great. So from 70 days to 45 days. So it's still taking over a month to make the diagnosis. If you're relying on plain films, or we end up seeing a clear, eroded, bad infection, well, you're way too late. You're too far into the process already. So we need to think about what we can do to sort of change this. Now, here's another example for an early infection, but this is also looking in retrospect now. So mild changes, some edema at the disc space. That, however, was read as being degenerative. Patient, 3 months later, with now a clear raging infection in that area. You can see also the edema or psoas sign around the outside of all of this. So what could have been done? Actually, clinical tests, CRP. This is the main tool that is used by the infectious disease doctors, but oftentimes is not done. So it helps sort out any sort of, whether cancer, infection, fracture will typically be elevated, whereas if it's negative, you typically can just rely on something benign going on. Additionally, it's been shown to actually decrease the diagnostic delay. And here, kind of shown from this one paper, that it dropped down. If they drew a CRP, the diagnosis time went from 73 days down to 17 days. Interestingly, X-rays made the length to diagnosis even longer, which is obviously a reassurance because at the beginning you're going to get an X-ray and then they say, oh, you have degenerative change, and then they leave it at that. There's also some selectious bias in here because the more sick patients might tend to go directly to an MR at the beginning if they're really ill as well. So here's a case, similar, relatively early on as far as for an infection, although it does have some features that are a little more aggressive here, because on post-contrast we've got this epidural phlegmon and we can see the paraspinal edema and enhancement around it. This patient did have an elevated CRP. Our CRP at my institution is a 1 is the normal range. Anything above a 1 is elevated. Other places use 10. It all depends on where you're working. But in this case, elevated CRP, and this was biopsied and turned out to be Candida. So a separate case here, utilizing CRP in a sort of different manner. So this is a patient recently that we ended up doing. So very abnormal looking, because clearly we've got an abnormality in the disc space here, in addition to an epidural collection. And there's edema around the spine, and then post-contrast, we get this enhancement, yet still there's very little marrow change actually in the bone, but you've got this eroded disc, you've got an epidural collection, and a bunch of enhancement around it. So we biopsied, we went right through the abnormality, all negative. We got nothing from it. So, but the patient persisted to get, still sick. CRP stayed elevated even after 4 weeks. So at that point, we re-imaged the patient. And now you can see bilateral little collections off on the side. Now, actually, these weren't as much collections, because on post-contrast, they showed a little bit of enhancement. And on CT, when we went this time, and Naveen biopsied this one, this hyperdensity right here that he went after. And in this case, in the end, it turned out to be aspergillus. So we got both hyphae and the cultures from this. And this was all pushed on the fact that the patient's CRP was not going where it was supposed to when they were trying to treat with empiric antibiotics. Now, this is a immigrant in the US with back pain, night sweats. This is probably one of the more classic findings I have like this. We've got a compression deformity, kyphotic angulation in the spine, and then this subligamentous spread across multiple levels. Additionally, this is a nice coronal that actually came off of this one as well, and then this thin-walled abscess, or what's sometimes referred to as a cold abscess. And the reason why they call it a cold abscess is because these actually, if they're even more superficial, they're not hot, they're not inflamed, they're not red. You don't have the inflammatory response that you normally get when you're talking about pyogenic infections. So this is a more classic example of a tuberculous spondylodiscitis. And here's a separate patient and what they would look like on CT. Again, thoracic involvement, not much going on with the disc space, these thin-walled abscesses. And as Dr. Morrison pointed out when he had the one case of the coccidiomycosis, that additionally, you get these areas sometimes that look like they are tumor-like. So punched out area in the bone, sometimes mass-like areas in the soft tissues that, this is not coming from the disc space, this is going directly in. So you'll see these sometimes with mycobacterial infections or fungal infections or some of these atypicals. Whereas the pyogenic infection, same as I showed earlier, thick-walled, ugly-looking abscess with it. So this is one of the few PET-CT cases that was done on someone. They were not doing it to look for a spine infection. This was more a cardiac issue. This patient was having fevers, night sweats, and back pain, and had a history of an aortic valve replacement a couple years ago. So this was actually done from the cardiac standpoint, and they end up finding this little spot right in here. And then this is prior to his onset of symptoms, and then by 6 months, which I think the PET-CT was done at about 2 months after his onset of symptoms, you have this very eroded area of the bone, soft tissue inflammation around it, coming out through that area. So it was actually his brother-in-law, who was an attorney, who turned around and gave him some articles and said, is it possible you have this? So this is Mycobacterium chimera, which from several institutions were in heart bypass heating cooling devices during surgery. So this was biopsy confirmed, and of course the issue with these over even TB is they're very non-responsive to treatments, and the whole goal is typically control, keep it from getting worse, more so than even cure. And you can see this, even on treatment, continued to progress. They did surgery. He came back 2 years from his initial onset of symptoms, new level involved. And we had previously imaged that level that had nothing. So despite all the treatments and surgeries, it continues to sort of march along. So we'll now move into some of the mimics of spondylodiscitis. So modic changes, Schmerl nodes, we'll go over some of these, destructive arthropathies. So this is the typical sort of modic changes where you get the low T1, high T2 signal at the end plates. Most of the time the disc space is preserved and you don't get anything else that looks like infection. So usually normal CRP and and no paraspinal inflammatory change. And this is kind of what we're looking at here. So these are the main two areas. Other clinical things might as well go along, and vacuum disc. There's some other ones, but the main ones to look at is no paraspinal soft tissue edema and no elevated inflammatory markers. Here's another case of motic changes here with the low T1, high T2. This time the disc space is normal, besides a little bit of a protrusion. No paraspinal edema, and on CT, actually, look at the extent of the sclerosis that is here through this level, even small little subchondral or underlying end plate changes, and a vacuum disc in this patient with motic changes. Schmerl's nodes, basically you're looking at one single end plate is the key feature here. So you might get even some edema in the disc space, but the opposite end plate's not going to be affected. And then on CT, you can usually spot these out real nicely. And then this patient, unfortunately, one single patient over a matter of about 5 or 6 months has 3 different Schmerl's nodes at different areas each of the time they came in. Now, I'm not sure what's with their bones, but interesting. Neuropathic spine, these ones are probably the most difficult to do because these are ugly looking disc spaces and you will end up putting a needle in them. The issue here though is how many times are you going to do that? So really destroyed disc, fluid, nodular enhancement as well. So this looks like an infection. Then in 2017, again, same thing. This was biopsied a couple times, and then finally you have to get where you end up saying maybe something else is going on instead. And if you do a CT also, you'll often sometimes on these find that both the anterior part of the spine and the posterior part of the spine are affected in this sort of unstable neuropathic spine in those areas. This case is a little bit different, meaning that this patient wasn't neuropathic, and additionally, this was called and concerning for infection because of this high signal, but there's not much edema around this at all. And we did biopsy it despite the CRP being negative, and everything turned out negative. And in this case, actually, if you end up really looking, this is a fused spine above this level. So this is a level that basically you have motion, and basically this is adjacent segment degeneration. Most of the time we see this following surgeries where they fuse, but it can also happen if they ankylose or fuse for any other reason. Post-surgical changes, microdiscectomy here, and following the microdiscectomy, you get again what very much looks like a motic type of change. In this case though, a little bit of marrow changes, edema, a new protruded disc, but you could take a look that there's no paraspinal edema, and the patient also clinically did not have an elevated CRP, and this was just normal post-op change. On the other hand, in this patient with a disc herniation here, who went to surgery, ends up with a tract coming right out from the area they did the discectomy out to the skin through the laminotomy site. You can see all this really bad enhancement. They tried to clean this up and put in hardware initially, but 2 months later, it just came right back again. And in this case, you can see these fluid collections around the pedicles and what is termed the pedicle screw fluid sign, which is a sign of a deep surgical site infection. And then this is sort of a separate thing that we've sort of noticed from time to time, and that is basically this very unilateral edema that occurs off of these areas with big osteophytes. You can see this really, really marked edema off of this area with these big osteophytes. But in the case where the edema is, the osteophyte is actually almost absent in that location or sometimes fractured. And we did go and biopsy this case. Everything turned out negative. The patient was not treated at all, no antibiotics, and actually improved over time. I'm not sure what caused the resorption, maybe if it was a fractured osteophyte, but if you see this completely unilateral, just had an osteophyte, sometimes this is not infection. This is another example with marked edema around these big, big osteophytes, and you can see at the one level, there's something, whether it's old fracture or something happened in this location, which is right at the level where the edema is. All right, with a little bit of time that we've got left, I'm gonna kind of quickly cover the facet joints, which is an even smaller disc space in a sense, so things spill out even quicker. So this is a collection coming directly from that facet joint, and mostly you're going to be looking for these collections around the facets that spill out much faster. So in this case, again, on the sagittal, you see this fluid collection, all this edema around it, And on the sagittal view, this ends up having this little sort of smoking pipe type of look to it, come in there with all the edema right out. Of course, that's only on the sagittals. I can't make this really into anything. And then in this case, this is more subtle with marked paraspinal edema around on post-contrast at an infected joint. And they can also be multi-level at a couple adjacent levels, or they can cross across bilaterally, where they cross behind at the ligament flavum and basically posterior paraspinal space. Symptom-wise, these differ basically in that they tend to be more febrile, they tend to be unilateral pain, and their duration of symptoms is quicker, and they have a more elevated CRP. So these were all the areas that are actually significant, including the fact, since it's an even smaller space, that they spill out into the epidural space much more frequently. So here's an epidural abscess that is coming directly from that facet, and this sort of leads the question. Old literature states primary spinal epidural abscesses were about 40% of the epidural abscesses that they found. They also said that septic facets were rare beforehand. 20 years ago, it was stated as rare in the literature. However, now we know that they're there all the time, and the vast majority of these cases are directly from the facets. So big, giant epidural abscess. Here, this was just read as an epidural abscess without a source. But when you look closer, you've got a thoracic facet that is directly coming out and directly feeding the epidural. So just a couple other facet disorders, gout, which we brought up before. Here, if you weren't positive, we can show that it is gout, PVNS, and then a synovial cyst, which typically synovial cysts will not have a lot of the edema around them itself. So CRP is the most useful lab and shortens the delay in diagnosing spine infections. SOA has a high sensitivity and specificity. Additionally, if you don't have a SOA and you have a negative CRP, you may be looking at something non-infectious. And then septic facets present more acutely and have more associated spinal epidural abscesses. And then if you encounter a spinal epidural abscess and you're not seeing a disc space infection, look at the facet joints closely. Thank you. All right. So our next speaker talking about interventions is Dr. Tito Rosas.
So I'll be talking about interventions. I wish I could say we say the best for last, but those three speakers are exceptional, and I'm just happy to be a part of this session with them. I have really no major financial disclosures. So it's kind of an interesting talk. They asked me to give a talk on what do I do when I encounter a potential infection. Usually the first thing I do is cry, because I know that I'm going to end up being asked more questions, and I'm probably not going to give as many answers as we saw, because as you guys saw, despite our efforts at getting multiple core biopsies and aspirations, we often don't isolate an organism, which is necessary for targeted antibiotic therapy. So pretty much for this talk, I'm going to talk about what we biopsy and when we biopsy. So number one, we're going to do our homework. I'll talk about the intake sheet that we have at our institution. But most importantly, we're really going to try to make sure that the labs and the imaging findings correlate with each other. And I think CRP has been talked about quite a bit, but that's going to be important to have an elevated CRP. And it's going to be vital that you always review the images to confirm that you actually think it's an infection. Here's our intake sheet. Not really important to go through. This is a reference for you guys. But we do an intake sheet mainly as a guide, and now the electronic medical record seems to be very redundant, so our clinical nurse will actually fill this out for us so that we have an idea of what's going on with the patient with all the inflammatory markers, what imaging has been done, whether they've had blood cultures. But the most important thing about this really is that we make the physician in our group who actually reviews this actually put their name on it. so that when the day comes for the procedure, if you've already approved it and the person who's on that day does not want to do the procedure, you are responsible for doing that procedure because you approved it. And that puts ownership on the person who's providing this, so that we're making sure that we're actually biopsying patients who need to be biopsied. And after that got instituted, there were a lot of cases that ended up not going to biopsy because people were like, well, I wouldn't biopsy this, so I'm not going to make my colleague biopsy it. And if I did, they were going to call me and tell me I got to come over and do the biopsy. So what do we look at clinically? Well, this has been talked about quite a bit. Fever, it's kind of plus minus 50 to 60% of patients will present with fever. CRP and ESR, as we talked about, CRP is high. I think this is most important, as we talked about again with discitis osteomyelitis. 90 to 98% of those patients will have an elevated CRP. So if you do not see an elevated CRP, you better think of other things other than infection. White count, in my family, we say más o menos. It's really plus or minus, really not necessarily going to be elevated, but it can. How about antibiotics? Well, our infectious disease colleagues tell us that if there's chronic infection, they want us to hold antibiotics for 1 to 2 weeks, but that's not clinically feasible in our clinical practice. If someone does come in and you're being asked to do a biopsy, honestly, you can wait 24 to 48 hours because most of the literature has shown that if they're on antibiotics, the yield on your biopsy or aspiration doesn't change as long as it isn't beyond the 24-hour mark. So you don't necessarily have to come in at 2 o'clock in the morning. You can go ahead and come in at 7 o'clock. You'll probably get a little resistance from that, but the literature supports it, so you can just go ahead and send them those references, and hopefully that'll help long-term for your kind of wellness and well-being there. IV drug users or people who are immunocompromised, we often will do anybody who even has subtle findings on imaging just because we know they have a high propensity for infection. So those I'll tend to agree to do pretty quickly. And then blood cultures, only positive, depending on what you read, between 30 and 78%. Some even say 20%. But where this comes into play again is with the spine. If you look at disguised osteomyelitis, we tend to wait 48 hours before we'll either aspirate or biopsy the bone, and that's because in 20% of cases, they isolate the organism just with blood cultures. And they've shown that if you wait those 2 days, there is no change in functional outcomes, length of stay in the hospital, or overall treatment. So we'll actually wait for those blood cultures, and our ID docs are also kind of on board with that as well. So contraindications, usually overlying soft tissue infection we worry about, so we try to find a safe track. There are a couple of new articles over the last 2 or 3 years that show that if you have cellulitis and you need to attack a joint, that the chance of seeding that joint is very rare. So some people say that you can go ahead and go through some inflamed soft tissue. We tend to try to avoid that and just find a different route. Inaccessible areas, pretty much I think the skull base is the only place I tend not to want to biopsy. Upper cervical spine, sometimes you can find some tricks, or sometimes deep, bone, but most of the time I think those are accessible. And then obviously if the patient has a coagulopathy. Now that kind of depends. If they're on meds, often you can reverse it as long as it's safe and you don't think that they're going to end up getting a stroke or a heart attack. If it's an underlying medical condition like liver problem or DIC, obviously then you have to weigh the risks and benefits of the procedure. If they have a history of bleeding complications, obviously that's going to determine, your route or whether you're worried. Again, I think the spine is the most worrisome area. If you're doing an extremity or a joint, usually not so much of a big deal. And then obviously high-risk procedures, we're going to get an INR and PTT. We do not stop anticoagulation for arthrocentesis. It's been shown that you can use a harpoon into a joint even if they're on anticoagulation, and they tend not to have any problems or issues. So, do not defer this particular procedure if the patient's on anticoagulation. Here are the SIR guidelines. I have the reference down below. It's a wonderful reference. High-risk procedures for us really entail mainly spine or vertebral body or anything near a nerve. In those cases, we will check a PT and INR and correct if feasible. We'll look at the platelet count, and then we'll transfuse if less than 50,000. For our lower risk procedures, which include sort of superficial bones like the iliac crest or bone marrow aspirates, joints, and bursa, we usually do not check labs. If they happen to get a platelet count and it's less than 20,000, at that point we will transfuse. So I think the most important thing is to review the imaging studies. So as a recap, we typically get a T1 weighted sequence, a fluid sensitive sequence, either a T2 or STIR, and then we get post-contrast imaging in most of the cases where we're looking for infection. And in this case, it's florid, discalized osteomyelitis. You can see confluent abnormal T1. You can see bone marrow edema with fluid in the disc. You can see a lot of enhancement in the paraspinal soft tissues and epidural space. So not really a conundrum. But interesting, when I ask my residents and fellows what is the reason they are calling discalized osteomyelitis, I usually get the answer because there's bone marrow edema and fluid in the disc. And my typical response is, well, are you 100% sure? Because really we're only looking at one and focusing on one thing, when in fact often it's incorrect, okay? So bone marrow edema and fluid don't necessarily mean that there's an infection. It's sensitive, but it's not very specific. I prefer to really look at the post-con if we have it, because it's been shown that this paraspinal and epidural inflammation and those psoas abscesses or epidural abscesses are obviously highly sensitive, 98% in calling discalized osteomyelitis. In fact, if that inflammatory tissue is more than 5 millimeters, it is really sensitive. So I prefer them to tell me it's because they're surrounding inflammatory changes rather than, bone marrow edema and fluid. And I like the T1s a lot personally. It's been shown often that if there's more than 50% of involvement of that vertebra, that is pretty diagnostic that that's not going to be motic changes and degenerative. It's probably going to be infection. So those are the things I'm looking for discalized osteomyelitis. I probably get 5 to 6 of these degenerative spines, where they're asking us to biopsy, and I could probably have my entire day filled every day with these. But we got to be able to differentiate between degenerative disc disease and true discitis. Here's a case example. This is a 31-year-old female. Requisition said FU. I didn't have any prior, so I don't know if that meant follow-up or they were having a bad day, but irrespective, that's what we got. They had an enlarging, painful thigh mass. Labs were normal, no history of trauma, and the diagnosis from the outside was that this was either a tumor or infection. You can see it looks pretty bad, right? It looks like there's an infiltrating lesion in the quadriceps musculature. You can see some patchy areas of T2 signal, patchy areas of edema. There's rim-enhancing fluid collection, but if you look closely, it looks like there's some bright areas in there too, probably some hemorrhage. If we look at the fluid collection, does it really look like it's under pressure like an abscess should be? Well, that's kind of weird that the border is somewhat concave. And then what is this horn coming off of the femur, which is kind of weird? Why is there a big ossification there? You might say, well, what about the abnormal bone marrow, Dr. Roses? That's kind of weird. It's got low T1, bright T2, and enhancement. Isn't that an abscess and osteomyelitis? Well, maybe, but let's keep looking here. So we keep looking, you can see that the muscle still has a striated appearance. You can see that, again, we have some low areas, which could be hemosiderin or could be ossification or calcification. And this patient had chronic bilateral hip dysplasia, in fact, was pretty immobile and wasn't moving the leg. And so, although we were asked to biopsy, I decided that for $10, I could get an x-ray which would prove that this was myositis ossificans. So bottom line is, I think everyone should get radiographs before they do any of these procedures, because often the answer is on a very simple and cheap exam. So we didn't have to biopsy this patient because it was pretty obvious that this ended up just being myositis ossificans. Here we have a second case coming up here. This is a 22-year-old. She reportedly had pain for 2 weeks in her sternum. You can see we have some edema and enhancement in the manubrium and the sternum, and we were asked to biopsy this. I actually called the referring providers for you young people. This is what a telephone actually looked like when I was in my 20s. My daughter made fun of me, so I actually put a cell phone there, which I did use to call them. And the physician actually told me, I only saw her for about 5 minutes, and she said she had pain, so I got the MRI, and when I got the read, I just sort of referred her for the biopsy. So I actually called her up, and I asked her, can you tell me a little bit more what's going on with your sternum, because I didn't want to bring a 22-year-old for a biopsy when I see no inflammatory changes around the bone, and metastatic disease would be highly unusual in a 22-year-old. She actually told me she had difficulty for about 3 years, and the pain was getting worse, and that she's had pain at multiple sites. I asked her if she'd been worked up. She'd been biopsied 3 times at the outside, as well as the fact that she had some studies done. I said, can you get me those studies? Well, she did, and on bone scan, we can see that she had not only uptake in her sternum, but she had some uptake also in the medial aspect of her clavicle, and on her chest CT, which they had done several of, she had involvement of multiple ribs, which looked enlarged and sclerotic. You can see the sternum also enlarged and sclerotic, and the medial aspect of the right clavicle. But at this point, I was pretty positive that she had SAPHO, which is synovitis pustulosis and acne and hyperostosis. And so she actually told me she had every one of those symptoms, and we ended up sending her to rheumatology to be treated, and she did quite well. She actually sent us a nice present, her and her family, because she'd been dealing with this for so long, and when she was treated, she did so well, and we were the first to make the diagnosis off of the imaging without having to biopsy. Now, you could biopsy this. I will tell you, if you biopsy this, you have to send it for path, which will be negative, but you should also send all of your samples for micro, because with SAPHO, sometimes you get P. acnes growing out, and that's another way of kind of detecting this. So if you get P. acnes on your biopsy of a young patient with these kinds of manifestations, most likely it's going to be SAPHO. So again, we didn't have to biopsy this because we took some time looking at the imaging and talking to the patient. So why won't we biopsy? Like, why shouldn't we just biopsy these? And, we're busy. Why don't we just push them through? Well, mistakes happen, right? So here you can see that that is probably the largest paring knife I've ever seen in my life. And he was cutting vegetables, which goes to show that vegetables aren't good for you. But the best part of this particular case for me was they got the radiographs before the CT, and on the indication it said rule out foreign body. I don't know, even if you're not too astute, I think that it would be pretty obvious that there is a foreign body or this is a pretty big knife. But anyhow, the patient ultimately did well. Now, when we look at the procedures we do, you can see here that unfortunately this disc biopsy didn't go very well and they went a little bit too far forward. I don't think they were trying to get blood cultures at the same time, but maybe that was feasible because they didn't have blood cultures. The hard part about this case is when reviewed, really the imaging findings were not really in keeping with discitis or osteomyelitis, but they were forced to do the procedure and they ended up in big red. So this is not what you really want to do. Obviously, there are things that can happen. The patient ultimately did do well, but it required surgery because they had to obviously open up the chest to make sure that, or the abdomen, to make sure that when they pulled out the needle, they weren't going to bleed profusely. So things happen. So we have to be 100% sure that we need to go to do surgery, right? So once we do decide it's time to go ahead and move forward, what are we going to do? We're going to know what we're going to target. We have to find a safe course, and often we need a backup plan if we can't get a sample. So here's a 51-year-old female. Initially, she came in because they thought that she had an osteoporotic fracture, and they asked us to do a vertebroplasty. We asked for an MRI, which shows the fracture. You can see there's diffusely abnormal marrow signal, and the person reading the study astutely saw that there was some paraspinal inflammatory changes and asked for contrast. And when you see in the contrast, you can see that centrally this actually is an intraosseous abscess, and then you can see a paraspinal abscess with a lot of phlegmon and inflammatory changes. And when we spoke to her, she had been working in Mexico for a long time and surrounded by several patients who had TB, and so we were worried that this was tuberculosis. So we obviously targeted that fluid collection with an 18-gauge needle. She followed the rule of having an elevated CRP and ESR, and so we isolated the tuberculosis. On my second case here, you can see this is a 3-year-old who had a destructive lytic lesion in the fibula with periosteal reaction, and the MRI was pretty impressive with this huge subperiosteal abscess, a lot of inflammatory changes in the muscle, and you can see that the bone doesn't enhance, so we were worried that there was some necrotic bone. Again, elevated inflammatory markers, did have fever and a white count. And so we went ahead and targeted the fluid where we went after that subperiosteal abscess. This is what it looks like on ultrasound. Here's the fibula. This kind of large rind around it is this complex fluid collection, and then we just put a needle in and removed all of the fluid. Now you may wonder, why did I attack the fluid? Was it because it was simple and easy and a faster way of doing it? And the answer is, well, that's part of it, but more importantly, when we target fluid, especially if we can get 2 cc's of purulent material out, our yield goes up to 80%, which is what we want. You can see if we had targeted the bone on any of those cases, our yield goes down to approximately 30%. So always target fluid when you're looking at infection. Here's the same case that Dr. Morrison showed us with a necrotic bone. If we biopsy that bone, that's going to end up being negative, but if we go after that nice abscess there, that's going to be positive. Here you can see this patient on an MRI had septic arthritis and osteomyelitis of the femur. We were asked to do a bone biopsy, but you can see a pretty large joint effusion, easy to slide a needle in there, and we were able to isolate the organism without having to do a large bone biopsy, and we knew our yield would be better. So always target fluid if possible, okay? Here, the patient didn't have any fluid, so in these cases, it's a little different. Here again, we can see abnormal edema and enhancement. The disc enhances, so that T2 signal in there isn't fluid. It's really just inflammatory enhancement and a ton of paraspinal enhancement. This patient indication was WTF. Again, I don't know what these people are doing, but I actually called on this one because I had to know what that meant. It was, what's that finding? Because they had outside hospital radiographs that were weird, so that's unusual. But they were immunocompromised from chemotherapy. No fever, white count was normal, but again, elevated inflammatory markers. And as we saw in several of the other cases, you have to start thinking in these cases that this is some kind of atypical organism, right? It kind of skips over a little bit the disc. It involves multiple levels, and paraspinal soft tissues are involved. In these cases, we are going to get bone and disc in hopes of isolating some kind of organism. And in the spine, we usually do a transpedicular approach where we go through the pedicle into the disc, and then on our second pass, after we do one pass like that, we'll go through the other end plate as well. And this came back as Candida. And so when we look at the literature, your yield is pretty good when you go after those soft tissues. So if you don't have fluid, I think number 2 is to go after the paraspinal soft tissues or anything that looks inflamed. You can see if you just did the disc, that's almost as good as the soft tissue. So both of these are fairly good. But you can see when you get the bone in those end plates, it's only really 19%. So if you don't have fluid to go after, I think soft tissues are number 2. And then bone you can do as sort of an extra if you need to. But if you want to, just go after the soft tissues. And then planning is obviously important. This is a 53-year-old who was not doing well on broad-spectrum antibiotics. Cultures were negative, and she had what looked like discitis, osteomyelitis. I'm not showing the sagittal, but this is the erosive changes that were there. But you can see this is not the easiest spot to put a needle. Maybe you could come, from a posterior approach, but that is not a lot of bone to work with. So we just got creative, and you can see we gave contrast, turned the head, kind of separated the carotid from the vert and gave us a little window to go ahead and slide a needle in. So be creative with positioning. You could hydrodissect is the other thing you can consider doing with saline or anesthetic to move vasculature out of the way or a nerve out of the way. So often we have to be quite creative in terms of finding the approach. And fortunately, we told everyone not to talk to her so she wouldn't turn her neck in the middle of the procedure. And we ended up getting an organism on this one as well. So imaging modality, it really doesn't matter what you use. Obviously, CT is going to be helpful for complex anatomy, but you can use ultrasound or fluoroscopy as long as you know what to target. In terms of timing, native joints, usually we think of those as being, ASAP, which is true, but some of the newer literature from ortho has shown that if they don't take them to the OR for up to 24 hours, that there's no change in outcomes. So technically, you could aspirate anytime within that 24-hour window. If they have a periprosthetic infection, that's variable. Most of those are a little more chronic, so again, you can kind of wait. For the disguised osteomyelitis, again, 48 hours, we're going to wait and make sure that the blood cultures are negative to obviate the need for about 20% of those needing an actual biopsy. For our aspirations, we use at least a 20-gauge needle. Most of us like an 18-gauge needle. For a bone biopsy, it's been shown 14-gauge or larger is the best. And we usually want to get at least 3 cores. That's what they do for tumors for increased yield, and we kind of extrapolated that to infection as well. 2 cc's of fluid is your gold standard if you can get it, and that's going to help our yield. Joint lavage is actually, funny enough, controversial. The literature actually supports doing a lavage with either contrast or saline or something, benign. In the old days, contrast, they said not to do it, but now with low osmolar contrast, you can lavage the joint with it. And although the literature has shown an increased yield with a lavage, some of our surgeons think that it lends itself to false positives and don't prefer it. And at a recent, orthopedic meeting, they advocated not to do it. So talk to your orthopedic surgeon before you do a lavage. For us, about 75% want us to do it, and about 25% don't. Do not use anesthetic with preservatives. The preservatives are typically bacteriostatic, bactericidal, so you don't want to use anything with preservatives because then you're going to kill off your sample. So you just stay away from that. Labs, typical labs, we give gram stain and culture. For joints, we will get a cell count and crystal. It has to be native fluid, so don't lavage it and do a cell count. Greater than 50,000 white blood cells is positive. They will take them to the OR regardless of our cultures. And then if it's a periprosthetic joint and they get fluid, they use 3,000 at our institution in terms of how high the white blood cell count can be. And for bone, we want to make sure that we send for both micro and path, because sometimes you're surprised at what the results end up being. In terms of repeating, we will wait a minimum of 3 days before we'll do any repeat aspiration or biopsy to allow our stuff to kind of brew. We will send for path in equivocal cases. If you're doing a lot of periprosthetic injections, you can send for alpha defensin, which is kind of what the neutrophils kind of spill out in the setting of an infection, a periprosthetic infection. This is through a company, so you have to send it off, and it takes a while to come back. But according to the literature, this is 99% in determining the difference between an aseptic joint and a septic joint in the setting of someone who has a prosthesis. So that's pretty good. You consider holding in cases where it's not coming back if you're worried about atypical infection, because things like brucellosis and TB may take between 5 to 12 to 14 days to come back. And then in select cases, we do send off a PCR. Mainly our infectious disease colleagues decide which cases are going to go for either a 16S or an 18S as well. And I'm just going to leave you again with just kind of to hit home the point on these spines. Here you can see a 37-year-old female had chronic pain. Inflammatory markers are negative. Actually, CRP was 0, no fever, no constitutional symptoms, but this was read as discitis. She had a little bit of bone marrow edema, not really that 50%, a little bit of high signal, which is not fluid, it was just enhancing. And really, if you look, there was really no paraspinal involvement. So we weren't real keen on jumping to this, and there's a nice article that says if you repeat your MRI in like 3 to 5 days, that you should see evolution in the setting of infection. So that's what we recommend if we don't think it's infectious and we're getting pushed to do the biopsy. So she came back 3 days later, it was the same. She came back a week later, it was the same. ID was convinced it was going to be infection, so they did another one at 2 weeks, another one at 4 weeks, and it was all the same. So it was just degenerative disc disease. She came back a year later because her back was still hurting, and you can see it looks pretty similar. In fact, she had a little less enhancement, and so she finally ended up going for her interbody fusion in the long run because of her back pain, which was just chronic degenerative disc disease. So anyway, my take-home points is review our cases thoroughly, target fluid, then soft tissue, and then bone. Use the largest needle you possibly can get away with for these biopsies and aspirations. Plan a safe approach, and send the pathology, particularly in equivocal cases. I want to thank you for your time, as well as thank all the other people on the panel. Thanks. The rest of the speakers are going to come up, and if anyone has questions, we're available, I think, for another 5 minutes. See, I have some online. Says, what's your experience using CT with contrast and detecting epidural fluid collection when MRI isn't available and cannot be done on the patient? What other exams would you recommend? I think that one's yours. What's your experience with CT and getting epidural fluid?
Not very good, actually. They have to be a large epidural collection to be able to see it on CT with contrast. If not, you can actually do a CT myelogram. Is actually a little bit better for finding an epidural, although a lot of people don't like to do that much, but it's perfectly safe, and actually you'll see an epidural better than you do with CT with contrast.
What did I have to do the next question?
All right. Which one? This one, right? Yeah. Okay, so it is not infrequent to receive MRIs of gangrenous toes. How do you recommend reporting on gangrenous digits? The marrow is generally discordant but presumed infected.
Yeah, dry gangrene can obviously be a challenge. Again, you don't have the vascular supply to produce the T1 signal changes and enhancement. It can be useful to look at the viability barter to see if there's any, signal changes of osteomyelitis. But yes, you can presume that it's often infected.
You get the next question too.
Neuropathic joint.
What did you say? We have a question there too.
Oh,
I'm so sorry.
No worries.
I did not mean to ignore you.
No, you're good.
Let's do yours first.
Okay. My name is Samir. For someone who is not experienced and is early in his career as myself, maybe this question might be intuitive for experts like yourself. But you spoke about redo procedures and waiting for 3 days after going for another biopsy, especially for vertebral bone biopsies. Would you actually go through the same trajectory if you want to go for a redo, or would you prefer going through another trajectory? Especially since you might want to do the redo because it came in inconclusive, or...
I think it's a great question. Often I will try to sample a different area if I can. If there's imaging findings in another area that look also inflamed or look like they're infectious, I'll probably try to do a different track just because the first one came back negative. I'm super aggressive, so the ID docs, I actually have, I looked at our data, and so we take like 3 huge bone cores as well as multiple soft tissue cores all around. Like, we spend a lot of time trying to get as much sample so they don't have to come back. So funny enough, if you look at the literature, most people will do a second biopsy. The chance of you getting a bug on that is only about 20%, so it's less than the original. And then there's no real reason to do a third, so that has to be an open biopsy, and that's what the literature currently states. But we looked at our data, and we had 0 cases out of, I think, 1,200 cases where the second sample ever came back positive. But our initial positive rate is higher than the literature because we're super aggressive. But when we do bring them back, we try to go through a different area just because we're concerned that, maybe by some fluke we missed some area that's more active than another. If you bring them back, sometimes the one thing that can be nice to do, just FYI, like if it's more than 3 or 4 days and they want to repeat, I would say get repeat imaging. If you find a fluid collection that they didn't have before, that's where you want to target. And then those will definitely probably come back positive. And we've had some of those where it's been like a week or 2 and then they re-image and then they find, a psoas abscess and you're like, oh, great. And then you go, well, not for the patient, but great for us. And we target the fluid, and that would be helpful. So sometimes 3 days is a little soon, even though sometimes you get asked to do it a little earlier. But if you get to the 5, 6, 7 day mark, just get repeat imaging and maybe you'll find something to target.
Thank you so much.
One thing to add, we've had a lot of research on vacuum phenomenon in discs. And we've been asked to biopsy a lot of discs that look neuropathic and things like that. And we'll often, refuse it if it's a vacuum disc. It's extremely rare. You can get infection and gas or vacuum. Over, I think, a 10-year period in our study, we found like 2 cases. So it's very rare. We'll often do flexion extension views or CT with the patient on their stomach to look for vacuum. If we see a vacuum and we're setting them up for biopsy and we do the CT, we'll often say you don't need it, especially if the other factors are not positive. The other thing I've found, I haven't done any work on it, but infection hurts. And when you put the needle in, they'll often wake out of the conscious sedation if it's infected. A neuropathic disc doesn't hurt at all. And you can do whatever you want in there. And so we'll actually put that in the report, that if we don't want to bring them back for another biopsy, we'll set it up saying we think it's neuropathic based on these things.
Thank you.
So we have a virtual question. How do you feel about using gradient echo imaging to help distinguish osteomyelitis from neuropathic joint disease, marrow-related changes? My understanding was that if gradient echo is negative, then it's not osteomyelitis. Personally, we do not rely on gradient echo imaging to differentiate. I think looking at osteomyelitis in patients with neuropathic joint disease is very simple. Again, most commonly we're looking at the foot, and it's going to be contiguous spread. And the osteomyelitis is going to occur right next to that. I think the T1 is going to be very helpful. So I look for the T1 signal changes and the presence of an overlying skin breach, soft tissue infection. That's really what I'm looking for. I don't know if anyone else has experience with gradient echo.
Yeah, gradient echo imaging is problematic because the marrow signal is partly dependent on trabecular density. So The signal characteristics are not great, but it's advantageous because it can be a fast sequence. So you can use it to acquire like 3 planes, pre and post contrast, for example, which is what we usually do our pre and post contrast as gradients.
We're 5 minutes over, so I'm sorry. So we have some more questions, but for those online, you can write any of us, and we'd be happy to answer those questions that we still have. Thanks so much for attending this session. I hope you enjoyed.